Welcome to the Master Series 2.0 from the American College of Healthcare Architects. Today's topic is a really exciting one: healthcare's response to health. My name is Angela Mazzi, 2021 president. I'm a medical planner at GBBN Architects in Cincinnati. And my co-host is Steve Tomplay.
Hello, everyone. I'm Steve Tomplay. I'm the president-elect of the ACHA, and I am a healthcare architect in New Orleans for Seisler Architects.
So now that you've met us, let's meet our amazing guests for this session. Dr. Ray Pentecost, FAIA, FACHA, is the director of the Center for Health Systems and Design at Texas A&M University and holder of the Ronald L. Skaggs and Joseph G. Sprague Chair of Health Facility Design, with faculty appointments in architecture, medicine, and public health. Ray is the 2020 to 2023 Global Director of the International Union of Architects Public Health Group. He is a past president of the International Academy for Design and Health in Sweden, a past president of the American College of Healthcare Architects, and a two-time past president of the AIA Academy of Architecture for Health. Carlos Marcet is a licensed architect with over 4 decades of professional practice, primarily with design and planning of healthcare facilities. He's a senior architect and project manager with the firm of Studio Plus in Fort Myers, Florida. The arc of his career has included work for a wide range of institutions and organizations and all types of healthcare settings, but he holds a special passion for the development of healing and wellness environments and improve the lives of underserved populations. Molly M. Scanlon, PhD, FAIA, FACHA, is an environmental health scientist and licensed and certified healthcare architect exploring the nexus between health and the built environment. Dr. Scanlon has collaborated with 50-plus leading organizations on environmental health topics, including the CDC, the NIH, the Mayo Clinic, and Kaiser Permanente, among others. She recently served as the American Institute of Architects COVID-19 Task Force appointed chair for alternative care sites and public health advisor for Reopening America. Dr. Scanlon was awarded citations for AIA Citizen Architect, an AIA Presidential Citation, and Healthcare Design Magazine's Industry MVP for her duty to public service during the pandemic response. She has 30-plus years of design experience for healthcare settings to create environments benefiting the health, safety, and welfare of patients, nurses, physicians, and staff. Currently, Dr. Scanlon's research focuses on water safety for design and construction in shaping standards and health policy to reduce the risk of injury, illness, and death from building water systems.
This question is about the scale of healthcare, and we want to consider the difference between what's going on at cities, regions, countries, and globally. So Ray, what's your take on this?
Well, what I've noticed over the last year and a half, 2 years, is two things happening really at different scales. An awareness of health and how it is impacted by design. On the one end of the spectrum, we see the work that's been done by Lord Nigel Crisp in the UK. He has a book out recently, Health is What Happens at Home. And that brings to mind the issue of what we do that takes care of our own health, the things that we are doing that are impacting health, and in fact, how the technology of healthcare is reaching into the home. So that trend, that whole movement with technologies and public health awareness, that's very much alive and well. But we also see with the COVID experience how, as Friedman put it, how absolutely flat the world is. And we see the vulnerability of the world to disease where national borders really don't mean quite as much in the world of health as they do in some other spheres. So we're seeing global connectivity happening at the same time that we see this preoccupation with what we can do at home. So I see the two developing independently, and they'll connect at various touch points for different reasons in different cultures in different ways. But those trends are happening, and they're the extremes, global and personal home. And the touch points are really where the interest happens for those of us in healthcare.
Interesting, a micro and macro scales kind of both operating at the same time. Molly, what's your take on this?
Well, when I saw the question about scale, so public health has something called the ecological model. And the ecological model addresses that all interventions must happen at all levels. So an old example is smoking. So below the city and that type of level is, as Ray mentioned, there's individual, residential, communal, community, and then it moves up to city, et cetera, and then it's considered policy at that level. So if you think about smoking, I always tell people they targeted the individual first, right? Quit smoking. Didn't work. They were addicted to cigarettes and nicotine. So what they did was they went up the ecological scale and they decided to attack a government policy. And I quiz people on this, but it was the elimination of smoking on planes or the segregation of smoking on planes. Then they went to secondhand smoke. Then they went to, we don't want to affect your children. So they go up and down, and the touch points are up and down and continuously back and forth in order to have the same outcome, reduce smoking and reduce the burden of disease. So in public health, they'll tell you, you will never achieve health of any outcome without a multiple level intervention. It just doesn't work because you have to communicate with people individually, collectively, in workplaces, in their society and culture. And until you have the stratification of that intervention across all of those scales, it will remain unsuccessful. And so then they also find out, like with smoking, they could only get the population down to 10 and 15% of non-smokers before another generation comes and has to be convinced all over again that smoking is not good for you. And so those are time cycles too that look at things like that. So you think you've eliminated something and then it becomes a generational response. So those are the things I think about when you think about scale, is you can't suggest that it'll only be tackled here or there. It's a much more fuzzy set of boundaries than that.
Interesting. Carlos, are you seeing a similar pattern in your work?
Absolutely. As we go through different scales, and it might be a major urban center down to, say, a very rural setting, which is an area of interest of mine, healthcare as it happens in rural settings. It's quite different. When you look at communities that are perhaps have populations with greater wealth and the access to healthcare that those people have, and the technology that's available to them for those interventions is far from what you see at a rural setting, where there might be a hospital, it might be the only one in the entire county that is somewhat government supported, and yet their resources are much less. And so the ratio of provider to population is greatly different, and just the technology that's available to them. Layer on top of that the nature of the populations in these rural settings. You have people that are maybe less mindful of their own health and the choices that they make. And so they have greater health problems, and you see a much greater incidence of smoking and alcohol abuse. Perhaps, what they eat on a daily basis is not as healthy as, say, some of the urban dwellers that have access to, places like Whole Foods and organic foods and things like that. And so not only are there resources not as great, but the choices that are made are different. Their priorities are different. And so it becomes a real challenge for rural-based healthcare providers and systems. Yeah, it's healthcare has to be addressed at all of these scales. And I see it particularly in certain counties here in Florida where they're all within the same county. You see a wide spectrum from one end of the county to the next. And then the two meet in between.
There's another sort of scale to what she was talking about. And the COVID experience has highlighted this for everybody to see. You can't miss it. All of the policies and guidelines and restrictions and penalties and incentives, all of those things within one country can be eliminated or completely dismembered by someone coming in by air or across a border, or any the connectedness of our nations has become such a glaring issue for us. And the imperative has become not so much how can we come up with a model of touch points to modify an individual's behavior or one culture's behavior. The challenge now is how do countries cooperate across what traditionally have been borders? How do we work across those borders, across cultures, across social norms, across policy differences?
Right.
And that question now has come right in our face with COVID. If you've got a really strong set of policies in one country and people from other countries coming in with different values, different behaviors, different histories, medically and otherwise, it can completely disrupt an otherwise reasonable approach to managing that disease. So the idea of multiple touch points, multiple scales, multiple ways of trying to achieve an outcome. Yes, the ecological model is central. It's a beautiful model. It's a necessary approach, but it becomes a very challenging thing to consider that across national scales, across oceans, across continents. It becomes a scale that's almost inconceivable and challenging to try to manage.
Very interesting point, Ray. And I think the word challenges is highlighted multiple times in which you were describing. And our next question kind of takes that and spins it a little bit to see what all these players in the spectrum of healthcare can do with this. So I'm going to start with you, Molly. From your unique vantage point, the health systems, which are as an individual, that's one of our closest touch points for our individual healthcare. How do these healthcare systems interface with governments, like Ray said, and nonprofits, NGOs, to have a positive impact on health, to overcome these challenges? And what role can these health systems, which are driven by their own criteria and their own motives, play in wellness for both us individually and as communities?
Well, what I found is there's, and before we started, you guys were talking about something that made me in this question. So in international settings, I feel they often put a higher value based on the number of people in public health. And so because the population is larger, they put more effort into general public health. And then the healthcare system is governmental run, or then they have a private system that's paid for. And so it's a stratified system, but they do have public health and they address that at large. And so it makes your decision-making different because of the numbers and scale. When you come to the US, it seems much more access based on a monetary situation of how you can get into the system. And so the whole public health model isn't really emphasized here in the United States to the general public. It's nothing but a health system. And their stratification is the fact that it's outpatient versus inpatient, which to me, that's not the same system that's working in the rest of the world. And so when you start talking about what was disappointing to me in the US during the COVID response was I wasn't even sure that the medical system understood the public health system, or vice versa. Why were these hospitals left on their own to make decisions? I was sitting here saying, oh my goodness, the public health system and the counties are supposed to set up an alternative care site or do that. But everybody was ill prepared. And so they just turn to their own resources, which is within. And it makes it very difficult to try to tackle a problem like that, right? The bigger the scale gets. So I feel like that in the US, it's different based on we're not a government run system of healthcare, at least not currently. And so I feel like the response is we've spent a lot of time stratifying what I call the traditional healthcare system, and I just don't think that works. But I'm a public health proponent or a public health professional now, so I'm much more after trying to deal with the population's health. And I think it's going to move that way based on some other things you might be asking about. Is it as access and all these other things start to supersede old selection choices of what was going on in healthcare? To go see the best doctor or the highest, best person, someone might want to do that in the past, but now it might be convenience over those types of things. And so I think it's hard to deal with this question because it's so government. It's who is delivering the care and what is the financial system behind it. That's what I feel like drives a lot of this stuff, is the financial process.
Yeah, if I could chime in here, I was speaking to a CEO of a rural hospital earlier today, and he was saying that healthcare in the U.S. is completely controlled by the payers. And of course, part of that is the government to different degrees, depending on the patient, depending on the level of insurance that is available to the patient. And I sensed a lot of frustration in his voice, especially, in this rural setting where, they are still bound by a federal law, which requires them to take care of any patient that comes in through the emergency department, regardless of their ability to pay. And I'm sure you've heard this scenario many times. And he's getting to the point where he's thinking, well, maybe a single payer system may not be such a bad idea after all. And I think he's willing just to blow up the whole system and just start all over again, maybe with a single payer system. I think that might be the way to go. The other thing that he mentioned to me was new models of care that are and payment that are beginning to emerge. He said that the current state of primary care doesn't work, and that the new models that are beginning to emerge, like in places like Oklahoma, where you have direct primary care, and so you almost cut out the whole insurance industry completely, and you go direct to the provider, and there's some sort of payment system or membership system or something that eliminates all of the excessive waste, as you see now. So he really thinks that the direct primary care may be the way to go.
Interesting. Ray, your thoughts?
Sure. I've talked about this publicly, and I won't replay the tape for those who may have heard me talk about this before, but I still think it's the best answer. I think the health industry has an opportunity to capitalize on an asset that maybe was undervalued in years past, but which in years to come will achieve greater value maybe than ever before. And what I'm referring to is their social capital. Healthcare systems typically are industry leaders in their community. They're certainly community beacons of light and hope. It's where a lot of community leaders are employed, certainly where a lot of community leaders receive help when they have a healthcare need. And the opportunity in the medical industry, and let's call that what it is, the medical industry, health care industry has an opportunity to take all of that social capital, all of that goodwill, all of that visibility, reputation, legacy for impacting the community in a positive way, and simply reframe the argument. Instead of saying, this is where you come to be treated medically, we need to reframe the argument, this is where you come for your health. And if they'll take that, I think they can participate in what the business people call a platforming strategy. And the transition that they can take advantage of is the transition from system thinking to platform thinking. And you can follow this in the behavior of our healthcare system. You see in the traditional system approach, the focus is hospitals, and you see aggregation happening for the sake of scale. And we build it around an economic model. Bigger means we can have lower unit cost, or the aggregation of patients for higher volumes. You see centralized operations. Remember the hubs with the spokes and the growing concentric rings of care. Centralized operations and an economy of scale, centralized management, production control. You control the technology, you control the throughput, you control the volume, you control the clicks, you control the payments. Ownership of those assets, it was all about acquisition and growth. But in platforming, you see a different set of priorities. In platforming, you see thinking that is consumer centric. The aggregation is for the consumers, not for the delivery. Tailored products and services for the consumer, meaning it may not be everything available, everything known to man. It may be customized for that audience. The control of the network is about what the consumer needs, not what is technically possible. And you see independent suppliers coming in. They don't need to own everything. They can contract for it. And where the platform works in healthcare, I've labeled it the NATO approach, and not because I'm so clever, but the business literature talks about this. And the NATO stands for establishing a niche, building an audience, with that audience establishing trust. That's the NAT. And the O comes after trust. It's where you can offer new things. You look at a healthcare system that established a niche, built an audience, established trust, they're poised to do the O in the NATO model. The underpinnings of a platform approach exist for healthcare systems. And I'm convinced if they will build on that and make their transition, then they can take what has been their traditional strength and make it their strength going forward, instead of the liability of being left behind. I think they have a tremendous opportunity. We may talk later about what it's going to take full advantage of the platform strategy. In fact, I hope we will. But for now, let me just say, I think that's their opportunity to become part of the health movement and move beyond the focus on medical.
Yeah, there's one thing I think is interesting about your model. Reminds me of a community hospital in San Diego where I'm at, but they also had the philanthropic control at one time, you know, because those community leaders were all giving into those healthcare models, right? And they have some of the strongest philanthropic arms and donators. And so if you're in an access to money, because what I thought was really interesting in this pandemic was I had given to the hospital, the local hospital, and we had a team of us that had tried that saved the hospital, made it a niche and did things. And during the pandemic, they were able to then revert back to being a community hospital to say, we're going to set up the vaccination clinic. We're going to do, right? So they became something to the whole community because they were there. And those of us that were donors, we were asking and going down, we were able to get the vaccines, you know, we were able to get access in. And so that philanthropic arm was their strength. So that's another part of your social capital model that I think they have very good skill sets at that need to be leveraged differently.
Great point. Great point.
Really is about targeting. And when we can not try to treat health as one size fits all, we can have greater impact. So I want to pivot now to talk about those specific care touch points and the mix of settings that we really need to provide for portals for patients, whether they're accessing wellness or accessing healthcare, to really try to move the needle and get those optimal outcomes. So Carlos, with your work with rural and underserved populations, what are the challenges you see and what are some of the strategies to try to advance the access to care and compliance with care?
Certainly. So I've worked with some organizations that service the LGBTQ community, and they're finding that they have to go into certain areas, typically urban areas, and set up shop with a clinic. Sometimes it's the renovation of a warehouse, and set up a clinic very quickly to offer the services to patients that might be being treated for HIV infections. And they go into certain areas. It's not like setting up shop in your suburban areas, but a typical urban area where it might be a little gritty and kind of an arts scene. But at the same time, being able to offer a great degree of privacy to these patients. So that's one area that I've seen. And then along with that, also being able to respond quickly to where the need is. And in one case, exploring the use of prefabricated clinics, using shipping containers that are brought to a site and set up very quickly to offer primary care to patients. So that's one kind of unique and interesting angle. Also, this smaller clinics, again, serving the populations in the fringes for migrant farm workers. I think that there are government programs that some of these neighborhood health clinics can take advantage of as well. But being able to set up more permanent type facilities, and some of them with philanthropic support as well, especially where you have the lower income communities coexisting with very wealthy communities, all in the same county. I think there is that opportunity to set up those clinics, and a lot of those also include dental care as well, and obstetrics is big as well.
Pop-up sort of care.
Pop-up care, exactly. Right.
Bring it where it's needed.
Bring it where it's needed, exactly.
So Molly, what are you seeing in the public health sector in terms of strategies to get better engagement with health among the public?
Well, in public health, it's all about the socioeconomic of where you live and then where you work. And so I found it very interesting, a lot of lessons in the COVID situation, just watching this vaccine roll out. I think it's a lot less about the objection of the vaccine than it is about access and convenience. And so people need the convenience of being able to have time off or have it in the workplace, or things that are easily accessible from my home. So public health is all about the majority of health happens in the home, and the choices that you make in regard to that, and the whole socioeconomic and relationship to your physical environment. But I find a lot of this is down to policies and access. So even for myself, I have a family member that's about to enter into a heart surgery protocol for cardiac care. We're going to be in this over a 6 to 12 month period, but access has all been about me calling my employer. Can I get my time off? How are we going to restructure my workday? What's going to happen with this? No one's talking about that I have, 15 years ago, or even when I started in the industry and somebody was sick, it was like they had to leave the employment and go, they would just exit the employment. People were not as sympathetic to that as if you just didn't show up and you didn't fit into the 8 to 5 cycle. You just weren't welcome to be there. That's all the way from birthing children to something more serious, right? So Family Medical Leave Act and all these other things are helping to soften that for everyone and make access more. So I see it as part of policy, but I also see the smaller, more nimble approach of being able to get closer to where you are rather than this concept that we're all going into a larger system. So it always strikes me that one of the persons, I can't remember, Angela, on our committee said to us, hospitals have traditionally been always getting bigger, bigger, bigger. But I think they're about to face where the next generation is. This has to be very decentralized. And I think that you may see for the first time spatial programming getting smaller. And that's really a very big change. And I think that's what drives that part of the public health model. But I would like to see more of these workplace things for people to have access for all types of either preventative or other types of care.
Yeah, I really like that idea that by making it easier for people to fit care into their lifestyle,
Right.
that we make it easier for them to get care, period. Ray, what kind of trends are you noticing from your work at Texas A&M and your work internationally?
I think there are a couple of trends that we're going to see manifested wherever you are. So I'll shift gears and see what I see as broad trends. One broad trend that I think is inescapable is that increasingly, whether you're looking at health or medicine, either one, the reach is to the individual. We're able to talk to and communicate with and monitor individuals in a way that we never before imagined to be possible. That creates its own set of complications. But imagine the whole conversation, and this is a raging conversation. It's hard to get two health architects in the room without the conversation eventually turning to this. And you don't have to raise your hands if this is true for you. But how often does the conversation speed to market come up? And that, and we branch off into modular and prefab and accelerated and all of this technique that we have for putting up a building fast. But speed to market today is a sign in the dirt that says telemedicine available at this extension. Speed to market is a poster, and you're in business. And if the market makes, then you can follow and put in something in the dirt. If you feel like it, you can actually build a building if you need one, but you may not. Speed to market conversations have flipped dramatically recently. And the ability to penetrate a new group of people is pretty interesting. So that would be one observation. I see that across the board. People are using technology. People are using personal monitoring devices. They're using online services. The contact for the system is individual in a new way. It's always been the individual, maybe a little bit through a company, maybe a little bit through a group policy. But the contact to the individual is in a way that we've never experienced. And that portends what's coming, because all of the data analysis is also going to be at the individual level. Customization of service, genetic engineering, all of that will be personalized care. So this transition is not altogether surprising, but it is absolutely essential for where the industry is headed. The second observation that I would make, though, Angela, to your question, we're seeing right in real time what was foreseen by Dr. Breslow looking at eras of public health, where in years past, we saw the infectious disease era, and we saw these incredible breakthroughs in managing infection and communicable disease even. We saw a second era that were kind of beginning to ease our way out of the chronic disease era. And we're all familiar with what those are and how they stay with us for long periods of time, and they represent an extraordinary cost in the healthcare system. But that chronic disease era in public health is giving way to a third. And the third era is fascinating to me because we're right on the tip of living it. And that third era says, for me, the consumer, for me, concerned about health, it is not so much about who's got the biggest magnet on their technology taking pictures. And it's not about who's got the most convenient facility. And it's not about who's got the most number of docs with the most award-winning this, that, or the other. For me, the consumer, the measure of success is I want to be able to do what matters to me. Now, if that means I need to be on an insulin pump, that means I can go for longer periods of time before checking in because I want to go hiking and I want to go ride in canoes and I want to go climb mountains, then great. Hook me up with somebody that knows that technology. If I want to do a triathlon for the first time at the age of 80, well, you may need an army of support to get there, but that's my measure of success. I don't want to know how many procedures you've done. I want to know, can you get me to my object of success in health? And when you shift the gear for the metric of success, when you change the measurement of what matters to, I just want to be able to do what matters to me, then all of a sudden, I'm not a data point in 40 million data points in last month's study. Suddenly it's my genetics, my cardiac history, my blood chemistry. It's about me and my outcome. And this whole wave of personalized medicine, it's not going to be if I were launching a company from scratch, it is highly unlikely that I would try to create the ultimate system by building it. I would create the ultimate health system by contracting for whatever I need that comes up that a guy might say or a lady might say, I need this to be what I want to be and do what I want to do. But I sure as heck wouldn't build one of everything. I'd contract it. And when you look at that platform approach, it's all consumer based. This is not happening by accident. This is market dynamics. And we've studied it. The economics industry can give us some really fabulous insights on how this works. But as we move toward this individual setting of standards, this is what a successful system is. It allows me to do X. You're going to see the people that dial into that and have the data to define that, contracting with whatever service is needed, wherever the nearest one is, to get the job done. And it's going to change the way the health systems work. The control is going to shift to the individual and the broker of that individual to all those little touch points in all those other different systems. But controlling it all like we've lived in the past, that's fading away.
Great. And I think what we heard over and over again was how contextual so much of this is with us as individuals and with health and all. And that leads us directly to it. Our next thought was, there's always been a little bit of the push versus the pull conflict with healthcare and the approach to delivery. And Molly brought up decentralization as one of the key points in that last question. So springing from that, Molly, which strategies are we looking at? Which should we take moving forward to start achieving some of these goals?
Well, Ray stimulated a lot of thoughts in my mind about that. When you get to that individual, I think it's all about convenience. So I agree that we're going to pick it the way we want it. And I think there are certain companies that analyze that data that are not currently in the healthcare market, and they may determine a different push-pull. So if you look at the whole Amazon effect or being Amazoned. They're sitting around looking at data of how categories of consumers purchase whatever, anything from socks to pencils to something else. And if they change that algorithm, then the whole dynamic can change if they understand what the consumer wants in that. And I think in healthcare, that's not been as much studied because everybody revolved around the system. And this is going to change. So I don't even know that people know the consumer behavior of what a healthcare person always wants. But I think Ray's got an interesting point. It's going to be driven to a secondary goal that is the consumer's primary goals. I want to go on a cruise. I want to go do this. I want to live my life, and I want to leave it as unimpeded as I can. And so that convenience marker. So I've been interested, and I brought some of these things up on our panel that we were doing for the ACHA's Future Look, which is all about the Mayo Clinic has interviewed all of the major technology giants and settled on Google because they don't want to be Amazon. And they have moved a Google campus to Rochester, Minnesota, because they want, and they are hiring, and they're coming up with what they think these algorithms are going to be to try to blend what might be called the traditional system to what this future system is going to be. But is that just going to be a modification of what we already have? Or are we going to end up with what I'm starting to see is how many people have seen, we used to see just pharmacology on television. Now I'm seeing doctors actually come on television and advertise, if you have X dysfunction, just call this number and we're going to send the medication directly to your door. They're going to treat without, normally you don't treat across state boundaries or, all these different things, which is what happened in the Amazon effect. I can now buy anything from anywhere and have it shipped the same day to my house. So it's like, why don't I? Or why don't I? If it's that convenient, I'm going to start picking things that way. So if the healthcare industry doesn't capture that behavior in some manner, or they're not familiar with how to, so another industry is going to do it, and they're going to take the cream off the top. And so I also look at it a lot like Tesla. Everyone said no one's going to move to these electrical cars. They moved as soon as the manufacturer started manufacturing one for the rich and the elite. They dropped Mercedes-Benz and they dropped the carbon-based car, and now their consumer is gone. And so everybody suddenly, the German cars said, well, we're all going to move to electric. They were never going to do that. But somebody took the cream off the top, and then everyone has to move to that place in order to respond. And so I don't exactly know what that's going to be in healthcare, because I'm not sure anyone knows what that behavior algorithm is to select health. And the one thing I was thinking of when Ray talks about social capital in the traditional healthcare system, see, I think epidemiology and other predictive models in the public health system that we saw sort of outplayed in the news media a little bit, but there's a lot more to it than that. Those models in public health, I think, could be matched up with healthcare to predict human behavior of what people want for health. But it's never been looked at from the lens that Ray's talking about. So I just think there's yet a combination, and maybe other people are doing this, but when I saw Mayo Clinic say, we're just going to go and partner with one of these big groups and bring the think tank to Rochester, I thought that was smart. That was really smart. I don't think we know I don't know what the outcomes from that are, because they're just talking about it like we are here with convenience and being able to use their phone. And they're starting to talk about it like it's going to be an Uber for healthcare type of thing. So I just think we're going somewhere, but I don't think we know the data analytics that are going to drive those choices that Ray's talking about.
Well, and that's great, because I guess it was inevitable if we start talking about push versus pull in healthcare and healthcare delivery, Amazon, Uber, and Google inevitably wind their way into our conversations, because that's what everybody else is talking about as well. and maybe it just hasn't got there for us yet. Now, hearing all that is wonderful and it's exciting, and it leads me then to want to ask Carlos, is this something in dealing with the fragile communities that you deal with so often, is this something to be worried about, or is this actually possibly a positive because it can maybe be tailored for some of these communities in a better way than the old models, which weren't very nimble?
Well, I think we're going to continue to see different scales of healthcare delivery. You know, I think we're going to see it at the large scale with the big mega companies, Google and Amazon and so on, and the very large healthcare institutions and systems, and they will deliver that scale of healthcare with, you know, the latest in robotics and diagnostic equipment. I think then there's going to be the other scale, and I'm beginning to see very entrepreneurial physician groups that are taking advantage of the latest in technology and providing cash-based care at a fraction of the cost of what the larger institutions are providing. For instance, I actually saw in a clinic here where these young physicians, they are probably in their, you know, early 40s, and they are offering cardiac catheterization procedures in cath labs that are not much bigger than 250 square feet. And they've got all the equipment and the imaging technology, but it's a lot smaller than what the hospitals are doing and putting into place, and at a fraction of their capital costs. And I believe that they are offering their services for much less, and yet they're out. They're telling me, and they're, you know, they're using the same manufacturer platforms that we're used to seeing in these larger hospitals, but the equipment is a lot more compact and everything's mobile. Nothing is fixed to the floor or the ceiling. Nothing is suspended from the ceiling. And it's all plug and play, and the imaging that they're getting is just as good as what you see in the larger hospitals. So I think we're going to see healthcare being delivered at those two extremes. And I'm afraid what we're seeing is that what we typically know as the community hospital or the rural hospital, they're kind of getting squeezed out.
In the uncomfortable middle.
They are in the uncomfortable middle, exactly. Are you any of you seeing the same thing?
I know that it seems that those clients in community hospitals seem to have more and more on their plate, dealing with attacks from all sides, as it were. The
Right.
very nimble small companies and the very large, exactly what you're describing.
Your conversation, Carlos, reminds me of two things. One, I had never seen this before. I was out and went by a physician who just had things posted on the door. It's a closed group. They had a certain number of people. He's taking cash paying patients.
Right.
And he's just offering, and he says, I'm not interested in your insurance, but the guy's a legitimate provider.
Certainly.
And so it's almost like he's creating his own self-insurance situation, and he's offering it, and people are willing to pay. They're willing to come in and pay. They just want access.
Exactly.
So that's one thing that you mentioned. The other thing, when you were talking about the cardiac cath or any reduction of that, I kept thinking, this is the same thing that happened in the 1980s, what I did my fellowship on, of taking inpatient surgery and moving it to outpatient. And everybody thought it was this crazy thing that you were going to do all these surgeries in outpatient setting for so much less. But hand surgeons and then all these specialty surgeons said, you know, we don't need this. What we need is blank, and they have to be licensed and controlled for health, safety, and welfare. But once you could get past some of that level, again, you're taking cream off the top of a procedure, but you are delivering it in a way where it improves access, and people are willing to pay
Right.
to get that. And so I think those models will continue to evolve, and we might be going, as Ray said earlier, through our next generation of those thresholds with the technology. And I personally think, I don't know about in rural communities, but this is what happened in international, what we would call third countries, is when the phone comes into the mix, banking and all these things, people say, well, they can't get to a bank, they can't do whatever. Well, they made it electronic through the phone. And so a small business person, you know, selling rice can deal with a bank and they can sell their product, right? Because you've flattened the amount of technology that they need to enter the marketplace. And so the phone can be a very big equalizer, assuming that everyone has access to one. And so there are certain things that can leverage people into being to that access by having that common denominator of a data phone.
Right. And then, so Ray, with the view from academia and looking at maybe some historic trends and how this is going with the push and the pull and getting more nimble and quick, what are y'all seeing that can maybe inform us out on the front lines?
When I look ahead, Steve, it's a fair question. When we look ahead, I think we are on the front end of a wave of mergers and acquisitions of a different kind than we've seen. Now, we just talked about Google and Mayo getting together. That's not a marriage that you would have seen during an era of systems growth.
Right.
You might have seen a huge health system merging with another huge health system to try to aggregate patients and technologies and providers, capabilities, and so forth. The mergers and acquisitions that we are beginning to see, and I am expecting to see a great deal more of, are the blending of I think it's 3 main elements for system transformation. The transformation to which I refer is the transition from a focus on medicine to a focus on health.
Mm-hmm.
The preoccupation in this country with health over medicine is only going to increase.
Mm-hmm.
Providers are going to reposition themselves to be a part of that. Now, think for just a moment, you're an administrator in healthcare, and you spend all of your years of training, all of your years of internship, all of your years of career ladder climbing, learning how to go to the boardroom and point to how much more volume, how many more dollars, how much more margin you've been able to create.
Mm-hmm.
And all of a sudden, you wake up in this really strange world that's sort of eerily familiar, but not really, where everybody's telling you, whoa, 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 don't use these facilities. Let's just keep people healthy. And we're getting paid to keep them healthy. And everything we spend on procedures diminishes our margin. Can you imagine what that's like to a health administrative cohort? I mean, that's a sea change. That's upside down.
Yeah.
And think for a moment about what that means to a system. In order to go from I'm focused on volume and dollars coming in to I'm focused on outcomes and dollars staying in, imagine what that requires. And it's not all that complicated, really. You got to have a bucket load of cash. Why? Because you've been operating your system for decades, assuming capital debt on buildings, on big pieces of equipment, on big pieces of lab analytic capability, on real estate, on medical practices that were required. You've been dropping capital like there was no tomorrow. And a lot of that is long-term debt that's not going to be retired quickly. In fact, the projects that capital was spent on very well may be obsolete before their debt is retired. So what do you need to transition from that model and those capital sunk costs into a model that says we're going to try to use these less and focus on keeping people healthy? How do you go from the volume model to something that looks more like Kaiser, where the value is keeping you healthy and out of the facilities? Answer, you need a lot of capital. So where is the capital? Well, you can go to a couple of places to find that kind of capital. One obvious choice is the insurance industry. And what have we begun to see? United and Optum, CVS and Aetna. This is not a great mystery. The merger of the provider groups with the people that have the capital to underwrite their transition and pay for those losses and carry those over time makes perfect sense. You're going to see a lot of that, I think. The other thing that factors into this transition, Steve, is the ability to understand information, the ability to bring information to the conversation. Now, you go to somebody like Google, you get both. You get capital and information. You go to somebody like an insurance company, you get capital and information. You can go to any provider and broker that information and that capital and find a meaningful partnership for a transition. It's a question of who wants to be out front, who wants to lead the transition. Do they have enough market share to make a transition really work? And the partnerships that succeed may be partnerships big enough to spread that risk, to diminish the risk in too targeted a direction. So Google brings a lot of other products to its line. It's got information and it's got capital, but it's got diversification. So I think you're going to find those kinds of partnerships to be real attractive in our next market cycle. But we have for years tried to understand how in the world do we take a private sector system focused on income and volume and cases and procedures and transition to something that looks more like the Kaiser Permanente model? And the answer is you got to have a lot of cash to sustain that transition. I think the industry's seen that. I think the partnerships that are emerging are the answer to that. And we're going to see that transition underwritten by the people who have both the capital and the information. Remember, we talked about personalized care. What's the driver for that? Personal information. You're going to see those industries coming together: capital, providers of services, and information.
It's really amazing how much disruption is going on in the health industry, and that we have really switched our terminology. We're not talking about healthcare anymore. That's just one narrow kind of slice of the pie. And we really are talking about a series of disruptors, everything from rising consumerism to personalized medicine, to different financial models, to uncommon partnerships. So in all this, the patient does seem to be gaining ascendancy, and one would think that's a good thing, right? But who then owns health delivery, and how do we know that if this is better? You know, what do you think, Ray? Is this going to get us a healthier population, a better world, or is this just the latest trend that's going to come and go?
It's a great question. And I think the answer is not yet clear, and I will explain why. I think there are some very practical reasons why we don't know the answer yet. Chief among them, and you know, that conversation is a great question, but it could go on for days. But the snippet of why I think we don't know the answer yet: we have currently exceeded our capacity to understand the breadth of the situation. I'll illustrate that. You've heard me talk, some have heard me talk about the Watson experience and the estimates that Watson reads every new clinical piece of information published around the world in about the time it takes you to drink your morning coffee. And the experts at IBM have said In order for a practitioner to do the same thing, it would take 29 hours a day. 29 a day. No practice, no sleep, no eat, no recreation, just studying 29 hours a day. We don't have that capacity. Individual records very soon will fill approximately 300 million books on each of us, 300 million books each. Personal story, a colleague here at A&M has somebody in California, 10 years of social data. To properly analyze that data, the estimates using the fastest computer that we have would take about 1 million years. We have projections, and I've had that verified by a second source. We're estimating that in 2020, which is come and gone, medical knowledge would be doubling every 73 days. We're projecting in the 2030s implanted sensors with 24/7 uploads to the cloud. Here's the practical reality. We don't have the technology to deploy AI and big data the way it's expected to be done. We talk about it a lot, and we're doing it on a small scale. But all the talk about AI doing millions and billions of pieces of data about millions and millions of people, we don't have that computing capability yet. So when I say we don't know who's going to control it, my take on it is we don't know who's going to control the information that drives it. We know how to create information. We do a real good job of that, but we have exceeded the human capacity to absorb it. We've exceeded our computing capacity to process it. That's the story to watch. Creating the data, that'll be interesting. But the capacity to analyze it to an actionable posture, that's going to be new and fun to watch.
Yeah, absolutely. And making the right kinds of queries of that data to really unlock things. Molly, in your work, you are looking at a lot of sets of big data. What insights do you have on this and what it means in terms of disrupting care models and introducing something newer and better?
I guess I was thinking when, as we've been talking, the thing that has fascinated me, back to some banking the concepts and money concepts and philanthropy, is that, as Ray's saying, we don't have the capacity, but I think new problems are emerging that require a new lens and a new look. And I don't know what that is for healthcare, but things like, so I never envisioned in the past, and this has been around for quite a while, but I didn't envision a Gates Foundation that starts to focus on public health. I didn't envision that in my early career. I didn't think a philanthropist, a guy that came out and started a technology company would then sunset his company, make so much money, and have enough money to drive public health. That's not a goal that a previous entrepreneur would have set. I don't know that I would look at, is it Richard Branson who owns Virgin, and we're going to have space travel by commercial flight. I haven't envisioned that these people would take on things that individuals have enough money to surpass what a government's money would in the past be able to do. And those to me can transcend some problem solving that if the right minds are put to that. So I see maybe people coming out of these. I mean, how much, I say this, but how much money can you make and how much physical assets can you hold? The world is now owned, there isn't that much unowned land or, something else. There's not that much more to acquire. How much bigger is this house going to get that we live in? Somebody needs 100,000 square feet to live in. I mean, there's not enough to purchase that anymore. So then that money should be put toward other problems to solve. And I think they're more humanitarian based. They're more environmentally based. And we've seen only a small smidgen of that in people so those people that we all talked about that founded the industrial age, the Carnegies, the et cetera, as they came here, what is that going to look like who are those people and what is that philanthropy that's moving forward? And my hope that that's more is in the public health realm that then becomes something that's applied to individual health. That's, looking at the planet and how long it's going to survive. I can never tell. Are we just in a cycle of things that die off because that's what age does to something like the planet? Or is it possible that humans can influence the length of its life by taking better care of it? So anyway, that's a wide piece, but I just see that those problems in those financial sectors and what to do with them are going to totally change. And we don't know we don't know who our industrial age or our environmental age and health age philanthropists are. I think there's just been a beginning demonstration of that, and that's going to change how things are going to look, because that's where the money, those people are going to have the money and assets to put that where they want. So recently I went over, none of you were there, but at the healthcare forum where they had, and I didn't know that Ted Turner was a conservationist. He owns half of New Mexico. I stayed in the most teeny weeny town on the way over in New Mexico, a little bed and breakfast that's owned by Ted Turner, that is a conservation so that you can drive out into the open area and enjoy. And there were dozens of people coming there to this place I'd never heard of. And he owns 3 bed and breakfasts in New Mexico because he owns half of New Mexico to never have it built on again. And so I think it's those, for me anyway, I didn't know that about him, but it's those kind of stories of people that are out doing something like that with the incredible wealth that they have. And it'd be interesting to see how those seeds that are planted mature and what does that bring us in terms, and who is that for health?
Yeah, and both of you have talked about these very large scale global and national influences that are playing out. They're almost seismic forces. I wanted to pivot to you, Carlos, because you are a practicing architect. And what are these things going to mean for you and your practice and the clients that you are working with? Do you think you're going to be building more things? What do you imagine that might look like given all of these disruptor forces?
Certainly. We haven't let up. We've been very busy here, both with, community hospitals and smaller organizations. I mentioned a small neighborhood health clinic that does receive government funding. And one of the expansions that they have undergone recently is a whole wing for education. And I think that's going to be a key component of healthcare, is getting communities together to improve their health literacy, and whether it's a community hospital that transforms itself into a community center, which I've always been very intrigued with, those hospitals that actually have been able to become that you go to these hospitals, 200-300 bed, 400 bed hospitals where they are truly a community center. They are still perceived as a healthcare provider, but they also provide a lot of social benefit to their own communities in that regard. And I think that we're going to continue to see that. And I think that's where that healthcare system at that scale can really thrive. But I think the same thing can even happen at these smaller clinics. I would like to see the government provide incentive, for those types of facilities where, you have an education wing and you draw people and you teach them how to cook. You talk about mental health care. We haven't even begun to scratch the surface there with this discussion. But mental health is a big component of healthcare. And I think people need to be able to support each other in that way and understand, that they're not alone when they have certain mental health conditions, that there is support out there. if they're addicted to something or, dealing with depression. So I think that if we can offer more spaces, as architects, we can maybe suggest that there are these spaces, these facilities that focus more on wellness. I think will be key. I don't know if the government is interested in funding those types of projects, but why not? It's a different paradigm. Somebody has to begin to think differently. Like Ray said, we don't have the answers, but we certainly need to do something different than what we've been doing. Something different will come out of all this.
So that has been overwhelmingly interesting and thought-provoking. Any last final words? Though I think each of you has aided the discussion immensely. Any last thoughts?
I'll bring something up for the good of the group briefly, Steve. Something that your audience, I think, might find interesting and valuable. The International Union of Architects at its July meeting passed a motion overwhelmingly to declare 2022 the year of design for health. This represents a global initiative. I'm excited to be able to tell you that. There will be more announcements about that coming out of the UIA headquarters in Paris. So look for those announcements to come. But events are already underway. Planning is underway. There's a great deal of excitement. And that will be a global spotlight on design for health for the entirety of 2022. And we're expecting that to continue beyond, because we'll be starting some initiatives next year that we know will have a life that goes beyond one calendar year. So factor that into your thinking, put it on your radar and track it. It's going to be an exciting time for everybody in the field.
Wonderful.
I'll close with, I made this part of my little talk I gave at the Healthcare Forum, which was, this year marks the 75th year of the Hill-Burton Act. And 2022 marks the 75th year of the first standards that were ever set up for a healthcare environment. And I said at the time, it was an effort that Armin Burgun was doing to try to remove healthcare from the prison codes so that you were not being held against your will. That was not the definition of healthcare. That was the definition of healthcare at the time, is that you were the same as someone who was being held against their will. And it was to set up these separate things. But I think that the pandemic is an inflection point of an arc. If we look back at our ancestry here of the many professionals from that point of Hill-Burton and bringing that forward 75 years, I asked myself, what is the next 75 years going to look like? And what are those people 75 years from now going to be talking about as the inflection point? It's not going to be the Hill-Burton Act, because that's going to be too old for that. But there's going to be other things. And I think we're at that time. I think the pandemic is a helpful mark point to that. So I say to myself, I've been after dropping the care word. I think it's design in health. I think that it is about health in all building forms. Because when I was serving as the task force chair for the AIA, for the national AIA, for the COVID response, I felt I struggled with my other design professionals who didn't have a background in any real health parameters. They did not really, they were trying, but folks that were designing schools or these offices, they were really struggling with, what is the transmission of disease? How does this work in these environments? What is the behavior? Who are these epidemiologists? There was none of that. And I feel that those of us that have dedicated our careers to health care can make a monumental contribution moving forward to remove the word care and start looking at this in health in all design, which is what some people are coining that. And that's really the public health model. I'm calling it the public health architect. And I think that's the place that we're going to go. And I'm hoping that the next 75-year arc, leaving the great foundation that has come from Hilberton to all the things we know now. But my question is, what does that lens look like? And that to me is a lot of fun to see that. But I think that's going to be, and that will be at 150 years, but we have a chance to shape that. And I think we can leave quite a legacy, just what was left for us to build on in the healthcare arena. And I think it's our job to take that forward and be shapeshifters and change what that's going to look like in the future. And that's what I'm looking forward to.
The health chimeras.
Any last thoughts, Carlos?
Yeah, I like what you said there, Molly, that we can be architects for health, not just healthcare. And I think that does need to be our focus. I also really think that we do definitely need to think outside of our national boundaries and really think about global health. So I'm glad to hear, Ray, what you were mentioning about the event in Paris. I'm going to look into that, and sounds very interesting. But I think that we, as one of the wealthiest nations in the world, really do need to reach out to those less fortunate nations and do what we can. And I've been fortunate to be able to be part of some mission trips with religious-based healthcare organizations, and have been able to see firsthand what a little bit of help can do to greatly improve the health of communities in third world countries. And it's tremendously fulfilling for me as a health architect to be able to participate in that way. So I think as a health architects, I think we need to look for those opportunities to go beyond our national boundaries for sure.
Well, thank you all so much. This has been such an amazing conversation, and it is not lost that our acronym ACHA could just as easily, that H stand for health as for healthcare. So we will definitely be taking that up. I know Molly and Carlos worked on the Future of Healthcare Task Force, and this was one of the task force recommendations. So it's good to hear it come back in this conversation, and I think it really is an important issue.
Thank you,
Thank you.
everyone.
Thank you. Thanks for having us.
Thanks.
Very